Okay. Tēnā koutou katoa, e mihi nui, e mihi mahana kia koutou. My name is Liz Tanielu. I'm a Chief Advisor with the Executive Board for the Elimination of Family Violence, Sexual Violence. It's my privilege to be the facilitator for this afternoon's session. Before we start, I'd like to offer a karakia. It's very much actually the karakia that is in the report that is going to be spoken of this afternoon. Kia ino i tātou. Tukua te wairua ki a rere ki nā taumata. Hei arahi i a tātou mahi. Me tā tātou wai i ngā tikanga rātou mā. Kia mau kia ita, kia kore ai e naro. Kia pupuri, kia whakamaua, kia tina, hui e, taiki e. Welcome everybody to the Evidence to Practice session. It's great to see you with us here today. As I said earlier, I'm your facilitator for today. In this version of Teams that we're using today, you will see only the presenters but you can ask questions via the Q&A function, so please take full advantage of that. Today's session, we are pleased to welcome Dr. Kiri Matiatos and Dr. Nicola Atwell, who are both part of the Mortality Review Committee, formerly the Family Violence Death Review Committee. Kiri will be presenting for about 15 to 20 minutes on findings of their recent Femicide report. Then you'll have a chance to ask Kiri and Nicola questions, facilitated by my colleague Cheryl Hahn, who's also Chief Advisor with the business unit. The Q&A is public. People online will see it. We'll get through as many questions as we can. And a reminder that we want this to be a safe and inclusive space. These sessions will cover topics of sexual violence and family violence that may be difficult or distressing. So please do what you need to do to look after yourself and get the support if you need it. We will post links to help portals where you can phone, online chat and find more information about help that's available. Now it gives me great privilege and pleasure to introduce the presenters. Dr. Kiri Matiatos is the Principal Advisor for Family Violence Mortality Review at Te Tāhū Hauora, Health Quality and Safety Commission. She supports the family violence subject matter experts by leading in-depth reviews of death events, coordinating their program of work, and leading the socialisation and uptake of recommendations that have been produced. Kiri previously worked in the health sector for over 20 years as a nurse and nurse educator in acute care and family violence settings. Dr. Nicola Atwell is the chair of the Family Violence Subject Matter Expert Group, previously the Family Violence Death Review Committee. She conducts specialist family violence mortality review work on behalf of the National Mortality Review Committee. Nicola worked as a social worker practitioner and academic for nearly 50 years before her retirement from the University of Otago at the end of 2022. She's currently an independent contractor providing supervision and training and consultation. Now handing it over to you, Kiri.
Kia ora koutou. Thanks, Liz, for the very generous introduction. I think I just got myself a PhD, which doesn't actually exist in reality, but I'll take it for today. Thank you. So as Liz said, I'm Kiri and I'm the Principal Advisor for Family Violence Death Review at Te Tāhū Hauora. So I'm just going to go through my presentation with you shortly, which I will just say is a real whistle stop. It's just a short presentation time and an overview of our report, and then Nicola will be joining me afterwards for some Q&A with you all. So yeah, bear with me. We'll just I think Alana's going to move my presentation across. Thank you. So as you can see from the title slide, I'm going to be talking about our latest report, which is entitled Femicide, Deaths Resulting from Gender-Based Violence in Aotearoa New Zealand. Next slide, thanks, Alana. So just an overview of what I'm going to go over. As I said, it's a bit of a whistle-stop tour, but it's basically we're going to give a brief overview of the Family Violence Death Review's latest report, which is their 9th report, and it's on femicide, specifically in the context of Aotearoa, and is actually the first report of its kind in this country. So we're going to talk a little bit about the background, just in terms of sort of where the report came from, what we're talking about in it, going over very briefly some of the key findings that jumped out at us from the report and some emergent issues, that kind of things that are coming up that need further attention. We'll give an overview of recommendations, which are kind of two-pronged, and I'll talk to that a little bit more at the end. What does this all mean for next steps, and really keen to hear from you all as well in terms of how we can help support this work. And as I said, time at the end for Q&A, and Dr. Nicola Atwell, who is an actual doctor, will come join me at the end to address some of your questions. So thanks, Alana. So by way of background, and I know Liz explained a little bit about where the Family Violence Death Review work currently sits in our structure. So the report we're talking about was produced by the Family Violence Death Review, so SMEs, we abbreviate the subject matter experts to SMEs, on behalf of our National Mortality Review Committee, which is now called He Mutunga Kore. So the report was published about a month ago on the 30th of June. And as I said, it's the 9th report from the Family Violence Death Review Group, albeit the first one under the new National Mortality Review Committee since the restructure a couple of years ago. So I think really importantly, just to frame this up, New Zealand's actually a fully ratified signatory to CEDAW, which is the Convention on the Elimination of All Forms of Discrimination Against Women. So we actually have legal obligations, as well as I think just moral obligations in terms of being good humans, to actually address our obligations under this convention. And it's all about addressing gender-based violence against girls and women, and really frames femicide up as a human rights issue. And just by way of a broad definition, there's obviously different ones around in terms feminicide, femicide, and different definitions provided. But in terms of the report, we've stuck with femicide, which can broadly be defined as the killing of women and girls because of their gender. Thanks, Alana. So a few years back, 2021-22, the United Nations actually produced a couple of really important reports around femicide. One was a sort of report on femicide itself, and the other was a statistical framework, which was geared up to help, I guess, globally, responses to femicide and data collection frameworks, etc. So while we've based this report on those guidelines, by UN Women and the UN Office on Drugs and Crime, we also went more broadly to look at an exploration of deaths that were associated with sort of further damage to women's bodies. So some things that included are the deaths of unborn babies associated with violence exposure, and also women and girls who die by suicide. So you'll see the term slow femicide on the screen there. And that's, so if we're thinking about, say, a direct homicide, for example, or a direct femicide, so where a woman or girl has been directly killed because of her gender, the slow femicide refers to when they might be experiencing gender-based violence, but that's perhaps a slower turn of events till they perhaps take their life by suicide as a result of the gender-based violence that they have been experiencing. And someone commented to me that they felt that minimised the harm from femicide by having the word slow in front of it, but I think it's really around just acknowledging that actually it doesn't always happen as an immediate event, and we've got this cumulative effect of harm that carries on from the violence that can lead to suicide, for example. So I think really with the report, we're trying to provide a much broader description and understanding of the kinds of deaths that women and girls are experiencing in this country. And it's broader than what was previously presented by the Family Violence Death Review Committee. So we're looking outside of just our family violence related homicides. Thanks, Alana. Key findings, some really significant findings that came out of the report. So I'm just going to go over these over a couple of slides for you. I feel like I'm not doing them justice because there's so much in this, I think, but obviously this is just an overview, as we said. So firstly, really, really obvious gaps in our current data collection. It's not something that's unique to New Zealand, but definitely replicated overseas as well, hence the statistical framework that the UN released a couple of years back. But it really limits our ability to even start counting, you know, taking a true account of femicide and gender-based violence within our country. And it also inhibits our ability to then target intervention and prevention strategies accordingly if we don't really know what we're dealing with. There's particular communities who are more invisible and silenced within this lack of data as well. In particular, documentation about migrant and refugee status, those living with disabilities, and also those who are outside of traditional male and female binary, particularly the trans community. So we know from other research that actually these communities of people are more likely to experience gender-based violence. So it's all the more important that we give them a voice, that we start to collect accurate data that's actually describing the experiences that they are having. Probably unsurprisingly to everybody, inequitable experiences continue for wāhine and kōtiro Māori, so Māori women and girls compared with non-Māori women and girls. And unfortunately, this is just not getting better. So we particularly were looking at some data from 2018 to 2022. And if we were comparing the rates for family violence homicides, so this is just looking at the family violence homicides, for Māori women and girls compared with non-Māori women and girls, had they been equal to the non-Māori rates, then that means that 25 more wāhine and kōtiro Māori would actually be alive today, which is, we get comments that sometimes that the numbers aren't that big in terms of our deaths, but as far as we're all concerned, one death is too many, and that's 25 more that could have been alive. Not to mention bringing the numbers down overall. But yeah, some stark inequities that basically persist. So I think it really speaks to the need for us to understand the nuances of how we can respond and the strategies that will be different for those different groups within our country. Thanks, Alana. Suicide and gender-based violence was a really stark reality in terms of doing this report. So we collaborated with New Zealand Police and our own data, and also looking at maternal suicide data. So just before I speak to that more, so maternal suicide refers to the suicide of any mum at any stage during pregnancy, including up to 6 weeks after the pregnancy has ended. And there is talk internationally as well as nationally about extending that out to a year postpartum, because there's also a lot of suicide that occurs in that time frame after having a baby. So we looked back on data, all the maternal suicide cases from 2006 to 2023, I believe it was, and 63% of those cases had a police reported family violence record. And that's staggering, considering we know that I think the general population, I think it sits, and correct me if I'm wrong, around about sort of late 20% of people that are actually reporting experience of just family violence alone. So we know that it's grossly underreported. And for this particular cohort of women to have 63% of them having a family violence police record is huge. So we consider this as still a significant undercount, which is pretty horrific if we think about that. And it really clearly identifies an important intervention point for better responses for this group of women, during pregnancy and after pregnancy. But yeah, quite distressing reading through some of those cases. Moving to perinatal mortality, again, some really significant findings here. And so just to clarify, this is around the deaths of the babies during that pregnancy period. So the sort of definition for that will be any time from 20 weeks of pregnancy, so 20 weeks of gestation of the baby, up through until the baby is born and up to the end of their 27th day of life, so sort of that first month after they're born. And this also does include terminations of pregnancy as well. So we looked at the data in terms of the number of perinatal deaths that were associated with violence at any stage during that pregnancy. And there was a significant increase over 2020 to 2022 compared with the 2018-19 period. Looking at reasons for this, yes, it could potentially be there's been an increased inquiry and recording of violence by health professionals, for example. But we know that there's a violence intervention program, for example, that runs in health, and we know that actually there's still a lot of room for improvement. So we certainly can't put all that down to that. I think what's really important is, again, it's another really clear opportunity for intervention to respond effectively to the violence during this kind of period. And if we just to talk a little bit more to the numbers side of that, we looked right across that period, so 2018 all the way to 2022, and we were looking at average perinatal deaths for that period versus annual family violence related homicides for women and girls. And the family violence annual homicides on average were 16 per year for that 2018 to 22 period, and compared with 40 perinatal deaths on average annually for that same period. So you can see that it shows a much greater loss of life that's related to an experience of violence than what we currently have been talking about in our family violence data set. So hence the need to go broader with our consideration of the deaths of women and girls. Thanks, Alana. Sorry, I feel like I'm rambling. I need to slow it down a bit. Emergent issues that came out, and again, some quite significant ones that we've sort of been grumbling away in the background, or that we're still wanting to know a little bit more, a lot more about, really. And one of those is around disability or long-term health conditions that place particularly older women at risk of family violence, homicide, but also homicide, femicide in general. So, and this is not isolated to older women. There's considerations here around those traditional gender roles and the caring role often that a woman will take in a family situation, for example, and this is not for everybody, but generally speaking. So the cases of this are reasonably rare in the data currently, but as our population ages, we expect that this will continue to increase, which is obviously of concern, hence it needs some attention. And an example of this, so we see cases like this in the media that often portray things in a certain way. An example might be an older couple. So, a couple maybe in their 70s, 80s, and the woman has developed a long-term health condition, for example, dementia, and the husband has now become her primary caregiver, and we might have it recorded in the media as a mercy killing. It may be like a murder-suicide, or like a suicide pact, for example, but the male partner lives. And often what's reported is that there's this, this immense care and that they don't want their partner to suffer, which may well be the case, but what it fails to actually consider is the victim's decision-making capacity within that scenario. If someone potentially, as I have just to give an example, has dementia, are they actually in a position to make such decisions? Is there a background of coercive control and other violent behaviours that are not portrayed? So it's sort of portrayed as inappropriately without taking into account, I think, the agency and autonomy and decision-making capability of the deceased female. So that's just an example there of what we're kind of talking about, and women obviously often ending up in a caring role, but then that being changed around and the risks that puts them at. Certainly seen in our family violence death review statistics as well. Repeated brain injury, I think sort of, been coming to the fore over the last few years, and not just in this sphere, but also in terms of sports, etc. as well. But if we think around like intimate partner violence and the very frequent occurrence of repeated brain injury, repeated non-fatal strangulation, which can have similar impacts on brain health, we know that there's a link, a relationship between repeated brain injury and suicide, as well as other forms of premature death. So it could be also just, poorer health outcomes in terms of mental well-being, in terms of other high-risk behaviours that you might enter into because of your poor brain health, etc. So, yeah, really significant in terms of that intimate partner violence sort of setting in particular. Thanks, Alana. So continuing with the emergent issues, this is one, organised crime and human trafficking, which I often hear from people, well, that's sort of like an overseas thing, right? Like, overseas with the international cartels and different countries. And unfortunately, it's very definitely happening in our country, and certainly not a focus of our report, but was something that's been highlighted as a risk area in terms of the potential for an increase in femicides based on, increasing trends with organised crime and human trafficking. I think largely speaking, there's certainly not a great public awareness around what's happening. We don't have an awful lot of available information in terms of those organised crime associations, etc., within New Zealand, which which limits our ability to be able to kind of intervene and look at those robust prevention opportunities. But I do know there's some great work going on in this space in the child protection and the health setting with police, obviously the immigration and justice kind of sector, and also I met a fabulous team of people connected to Oranga Tamariki as part of undertaking this report, who actually run the International Child Protection department. So there's some great work going on, but I think we really need to be mindful of the trends that we're seeing in international data to try and help inform us in terms of intervention and prevention strategies. And tech facilitated abuse, I think, is a really topical one. I think we're such a technology forward society. And if we're thinking about not just, particularly our younger generation too, our young girls, and not just young girls, young boys as well being harmed, but the potential for gender-based violence to really be driven high, and also contributes to deaths by suicide if we're talking about technology facilitated abuse. The research shows that, again, there's certain groups who are more vulnerable to this, and I've just kind of mentioned about the younger generation in terms of grooming and things like that, but also the ethnic and migrant communities again, and particularly trans women. There's some good international data and experiences of the violence they're facing as well, and women in positions of power or in the public sphere as well. So really quite some nasty gender-based stuff that can go on, and again that contributes to that slow femicide that I mentioned earlier. So it's really fast moving, the tech world. I certainly don't feel like I can keep on top of it. So we really need to look at comprehensive approaches in terms of our prevention and response strategies, because there's continuously sort of different and emerging forms of violence coming out in this sphere. Thank you, Alana. So recommendations are a big one, I suppose, as with most of our reports, but this report we actually split across two different parts. So as I mentioned at the beginning of the presentation, we're actually fully ratified country in terms of the CEDAW convention, and as such, we've got those legal obligations, and at the current time New Zealand is falling pretty short of meeting those recommendations. So those are things like, they're really kind of big picture systems and society-wide. So it might be things like legislation, things like data collection, the human rights element of all of this, putting that ownership on the state to actually act to prioritise the safety of all women and girls, those kinds of things. And then the other part of our recommendations is focused around collaboration with our stakeholders. So we had quite a bit of stakeholder engagement throughout the development of this report, as well as kind of the write-up of it. And we spent a lot of time with both agency and community stakeholders to, I guess, essentially co-design some recommendations that are maybe feasible, implementable, made sense for everybody in terms of how we might look at trying to facilitate some community responses that were improved. So I'm going to the next slide. Thanks, Alana. There's a lot of recommendations, so we won't be going through all of those. I've just sort of picked out a few bits to talk about. But I guess essentially with the recommendations and next steps in terms of this mahi is, as I said, it's the first report of its kind for Aotearoa. So we're aware that this is not going to solve all of the issues around it, but we really do hope that genuinely that this is a really important starting point in terms of having some broader discussions, broadening our understanding, so we can start honestly looking at prevention and response strategies that might be more appropriate to address this human rights issue, which we are currently falling really, really short of in many ways. And that's not to say that there's not some great work being done by, a lot of people and a lot of organisations already, but generally speaking, we've got a long way to go. We know that with these big issues, it's like lots of, work in the family violence sector, for example. We know that it requires actually a really collaborative approach. So we're talking cross-sector, multi-systems, government, community. It's a massive bit of work. So I guess it's how we start from, we've got the top down and the bottom up kind of approach that we take with a lot of this work. And some of those examples in terms of what we have found in the report is, coming back to that improved data collection and reporting. We know that data reporting on its own is not going to change anything, but I just like to say it is a really important starting point. It helps us to get a picture of actually what's going on out there and then to help inform our intervention and prevention. As with all of our work, and Nicola may well talk to a bit more of this as well in our Q&A, but taking a life course approach when we're responding to women and girls, and in fact anyone who's experiencing violence, like a lot of what we saw particularly in the maternal and the perinatal space is accumulation of trauma and unaddressed trauma, people having multiple perinatal losses, whether that's, you know, through violence, through a termination of pregnancy, miscarriage, that's not been adequately addressed, historical and ongoing family violence, sexual violence, grooming, you know, child abuse and neglect, whatever that form of violence might be, and people having significant difficulties with their mental well-being, with drug and alcohol misuse as a result of all of this stuff. So actually just seeing someone and saying, yes, we've done your pregnancy check, tick, everything looks fine and out the door, they're failing to address all this other stuff that's sitting alongside that, and potentially dealing with the loss of babies, etc. So a really big opportunity for a clear intervention point that could potentially save a lot of lives, not just of mamas, but actually of their babies as well, and trying to break that intergenerational cycle. I feel like I'm probably preaching to the converted, you know, the choir or whatever the saying is. I got that one wrong. Strengthening and supporting our existing community providers. So we know there's some amazing work being done at the community level already, but how do we make that easier with our, you know, our funding models, with flexibility in terms of ways of working, so that those community providers who understand the local need and the community that they're facing, serving, can continue doing the work that they're doing. And I think I just want to add in here too around care for survivors and responders. So for us as the kaimahi responding, it's really important that we get the support we need to be able to support these women and girls and their whānau as best we can, because it's heavy, heavy work. And we've talked about aftercare for survivors of family violence, homicide previously in several reports. And the same has come through really loudly when we've had lived experience engagement for femicide survivors. So it's not just about that intervention at the point of a homicide or a femicide. It actually really importantly has a preventative arm to that as well, in terms of trying to provide that wraparound care, interrupting then those ongoing downward trends for mental and physical well-being and violence experience and intergenerational violence that can happen as a result. So yeah, just some examples of kind of the recommendations that we're focusing on. Thanks, Alana. I think, yeah, that's kind of brings me to the end. I guess I just really wanted to put open the door, but also maybe a bit of a challenge out there. You know, we've come up with a lot of important findings and a lot of relevant recommendations in the report, but a real challenge for us in terms of our family violence death review work is how we then help to support those recommendations actually equate to some action and change in both agency and community settings. So this is going to look different depending where you're sitting potentially, although there's current themes. So really, genuinely, I've literally put my email address up there, slightly apprehensively, depending how many numbers come through, but we'd really love to hear from you. If there's some way that we can help with the understanding or with the dissemination or with supports around action to do with this in your specific organisations or areas of practice. So please feel free to get in touch. And I think there's just one more slide that says thanks, Alana. Yeah, so that's it for me for now. Thank you. I hope that was useful.
Thank you so much, Kiri. That really was useful, and I just want to, thank you and the group, the subject matter experts, for all the work you do to make that data visible, because it isn't available anywhere else, to share that with us, to share the analysis and the insights, which are really important, that have formed up those recommendations. And one of the things I really appreciate about your report too, which we put the link in the chat there, was, you know, how you describe current poor practice or concerning practice and what an example of good practice could look like in some of those areas. And I think that's useful for people as well to see what good could look like. And so following on from your presentation, I want to start with a couple of questions I had first, and then I'll go to the Q&A. So anyone who's watching, if you've got some questions, please put them in there, and I'll try to get those to Kiri and Nicola. My first question was for you is around, you know, the really important work that you've highlighted there that needs to happen to understand the links around violence and pregnancy, drug and alcohol misuse, suicide, and then that being the contributing factors for deaths of mothers and babies. And so I was thinking that means, you know, there's something there that it means for the wider health workforces, people who are in the alcohol and drug treatment, suicide prevention, who are in maternal health spaces, for them to have an understanding of family violence and a link into the family violence services. So I wondered if you could talk a little bit more about what you think that means for health workforces, and if there's any examples of good practice or promising initiatives that you could share or that you've found out about. Thank you.
I mean, I think we have very supportive responses from parts of the health sector, and I think there is a level of awareness. It's very difficult in the current climate because of the constraints on the health services, but for me, I think it's that really key point that comes out of taking a trauma-informed approach, where we need to be asking not what's wrong with you, but what's happened to you, and always understanding that whatever a woman is presenting with, there will be things sitting behind that, and particularly in the alcohol and drug field, that we need to absolutely, our starting point is that these are ways of managing our trauma histories, and that if we only focus on harm reduction or cessation, we miss the fact that people can only give up substances when they have other ways of managing their trauma and being on a journey of healing and recovery. So I think it's very easy for things, for example, like drug and alcohol, to be seen as problematic factors, that if women just address them, they'd be a lot safer and a lot healthier, when in fact it's this whole history of trauma that sits behind. So I think health is a universal service. It's one which everybody comes into contact with, and it is that constant awareness of the need to refresh, upskill, but not only to recognise, but for people to know what to do when they see something that worries them. And I think how our systems are not as well connected as they could be in terms of creating pathways. I think our midwives are very key health professionals, but making sure that the supports are available to them when they do see things that are maybe troubling, that can help them to get the right supports in place for women. It's not that we're not asking health professionals to do this all on their own, but it is the wider systemic support, particularly to our frontline health professionals, so they have places to turn.
Great, thank you. Thanks, Nicola. Did you want to add anything, Kiri?
Yeah, I mean, health has a special place in my heart, having slogged away at it for like 20-25 years. And my background is largely in the adult emergency setting. So I've seen a lot of these people coming through the doors that we're talking about, and also understanding the reality of your time constraints. You know, like you're working in a busy acute department where you're completely going from one fire to the next. How do you change the way you're interacting with those people to a much more relational, like actually just have a conversation when you've got, you know, everyone's pressure sitting behind you, moving through the department, do what we need to do. So I think there's definitely, you know, there's lots of good stuff happening. And as Nicola alluded to, we'd had some really good support from particularly the Royal Australian and New Zealand College of Obstetricians and Gynecologists, as well as the New Zealand College of Midwives in particular, who are kind of going through some similar stuff and identifying similar issues. So there are you know, groups and you know, strategies underway to actually start addressing some of this stuff already. So I think we're just figuring out how we can then support that to carry on. And I think just what Nicola said, you know, it's not, we can't expect them to be doing it on their own, although there is a really big intervention point, you know, for people coming through the health sector. And I think part of that is there's definitely an upskilling and training part to it, as Nicola said as well. But that's one part of it, you know, understanding our communities, where are those other supports that we can bring in to support in terms of the, you know, drug and alcohol services, in terms of the mental well-being, because, you know, one person can't do all of that and we wouldn't be expecting them to. Really just reiterating what you've said, Nicola.
Thank you. Yes, your report talks, so I think in the recommendations is around integrated approaches and integrated responses, that idea about everyone having a role and playing a part in that, and no one having to respond alone. And so that was one of my other questions, was around our kind of current environment for the family violence multi-agency responses, you know, like the FVDRC, Whānau, Napa, Harakeke, and the other different models that exist around the country. I was wondering, in terms of, I thought it was really important, your concept around slow femicide and highlighting that cumulative patterns of harm that lead to the deaths of women and girls and babies. And I was wondering if you thought that thinking about suicide needs to be brought into that multi-agency response environment, thinking about not completed suicides only, but attempted suicides, and that information being part of understanding the risk, and also, as you say, the ongoing patterns and the accumulation of trauma over time.
The multi-agency space is a very important one in terms of joining up the dots. And I think there are no one-size-fits-all ways of managing that. So I think communities are at different places in how well those forums are working. We've done quite a lot of work here in Ōtepoti, Dunedin, around the sorts of information that needs to be shared, and how we need to be really proactive about not just responding to what looks like high risk or imminent risk, but also calculating risk in terms of what we call cumulative harm. And I think once you shift the focus to cumulative harm, you're much more attuned to, for example, the impact of family harm on children and young people, and the potential for interrupting cycles of intergenerational harm by effectively responding to it as it occurs. But also it alerts you to those downstream consequences in terms of potential risk of suicide, but also alcohol and drug issues as people struggle to manage the impact. So it's really shifting away from what has been, I think, a bit of a culture of responding to incidents and on the basis of how how dangerous they appear to be, to really thinking about the bigger picture of people's lives, and the need, looking at our examples of what good practice could look like, thinking about how our Māori agency forums might be able to play an active role in developing those kind of responses at a community level.
Great, thank you. Did you want to add anything, Kiri?
Well, the only thing that's just coming to mind, and I think I was probably supposed to mention it when I was doing my presentation, was just around the suicide thing. You know, we talked about that slow suicide, and it's certainly not something, you know, yes, I agree with everything that Nicola said, that we've got good opportunities there at those multi-agency tables. And I'm just thinking of practice internationally. There was a case a few years ago in the UK where a man was actually charged with manslaughter as a result of his partner taking her life by suicide as a result of the violence that he'd inflicted upon her. So, you know, it's changes like that that's happening afoot kind of in terms of relating to that slow femicide. But as far as I know here, that hasn't been the case yet. Yeah, it was just really more just a comment around that.
Yeah, good. Thank you. Thanks for raising that. We've got a related question here in the Q&A. Adriana's asked a couple of questions that are related to the police and the courts. So the question is around, has this report been shared with the police and the courts? And what actions do you know if they're taking to protect women and girls from femicide? And the context around this is Adriana is saying from her experience, or from their experience, that police are only intervening when there's significant physical harm and may not have that understanding about psychological abuse and coercive control. So just reiterating, has a police report been shared with police and courts, and do you know if they're taking any actions?
Yeah, we tend to work quite closely with the police, and that is always a work in progress. We've been particularly concerned about some of the recent changes, which indicate a kind of stepping back in terms of what they are responding to. And we do know that this is, you know, a key risk factor in terms of when women and girls reach out for support, the response they get to that first attempt is really significant in terms of whether they will seek further help or not. And that if they have a bad experience, then that contributes to what we call systemic entrapment. So we're in ongoing dialogue around those kinds of issues. The courts is a very big system. We do have a representative on a body that looks at the judge's bench book and the advice that is provided to judges. So we do have input there. But there is a massive amount of work that needs to be done and could be done in both of those realms.
Yeah, and I'll just add too, in terms of sharing with police. So my work's done for Te Tāhū Hauora, which is the Health Quality and Safety Commission. So we're reporting indirectly via our board through to the Minister of Health. So in terms of the socialisation of this report, we were shared that report with the Minister of Health. So in doing so, we shared that with some other, one of our recommendations was to share it with related ministers in terms of their portfolios. And so we have been in touch with Minister Costello's office, so she's the Associate Minister of Health, but also of Police. So we're trying to make those connections from that kind of top agency level as well through government, and that will be ongoing stuff. And police have also been part of our stakeholder engagement and developing this report as well, and we'll continue to, as Nicola says, be really closely engaged. So I feel like the cogs go pretty slowly, but yes, we've tried really hard to bring in, like I said, this goes across all of government, so there's some real key players, and police definitely being one of them as well. And the courts, I know there's a lot being done with our Ruth Money, our new victims advisor, etc., who is kind of continuing to do lots of work in these various spaces. So watch the space, I guess.
Great. Thank you so much.
I just noticed, a subset of Adriana's question which is, how can we break the barrier down, because they're not always going to police. One of the things that we've started to, that has started to happen here in Ōtepoti is direct calls from the community to our Whangaia Harakeke Family Violence Coordinator. And these are situations where there is a concern and people don't know what to do. And so we are using that multi-agency forum to provide support, not just in cases that come through the normal channels, but also in extending our reach into the community so people know that there is support available to them. For example, one of the things that can happen is sometimes we call a professional hui. If it's a very complex situation, we get everybody together, we make sure that there is an identified key person and that they have access to support. So I think we need to really expand I think a lot of people see the multi-agency forums as very much police-led or police-dominated. And I think it's really important that we break that down as we move forward, that these are a community resource. Police are a very key partner in that, but they are not the absolute sum total of what's available in terms of intervening or getting support. It's not about intervening, it's about getting support to people.
Yeah, that's really great to hear, because we know from some of that population-based research that where people go to seek help or disclose violence is mostly friends and family first, but then after that it's community services and the health system, isn't it? So, having those other pathways, it's great to hear that. Something you said before, Nicola, about the real importance of that first response, about whether someone gets help or whether there's systemic entrapment by ineffective responses. There's a question in the Q&A around whether you looked at, and it sounds like you did, when you're looking at family violence that leads to femicide, are you considering the institutional and legal system responses? Are you taking those into account? Because this person says, in my practice, when a woman is caught in the system that abuses them, systemic coercive control, she reaches a level of hopelessness.
Yeah. I think it's been a consistent theme in the reports across time, but it is something that we do always try to highlight, and that often our little case vignettes in the what actually happened often show the barriers or the points at which women became more entrenched because of the lack of a response. So our alternative scenarios, and I mean, our alternative scenarios are not quick fixes, because actually they are about doing things different the first time someone reaches out or the first time there is a cause for concern. And so a lot of that, I mean, one of our reports focused in on what we called the duty to care, and embedding that across all our government sector agencies, but also across, all the other sort of more in perhaps less formal support services is probably the key to making. It's the only way we can make inroads into that systemic entrapment. And for me, the question is, if someone's presenting and you're not the right person or it's not the right door, rather than just telling people that we need to think, if not me, then who, and make sure that we have the conversation that opens some other doors for people. I'm haunted by, some of the examples of systemic entrapment. In one case, a young mum who was homeless, and that was a key factor, and her difficulty navigating the system to gain secure accommodation for herself and her 3 young children was a direct contributor to the loss by homicide of one of her babies. And those are things that are avoidable and preventable. And she had actively sought help and was actually being helped by an agency, but in the meantime, she wasn't able to secure the return of her child, and they died at the hands of another person. So, yeah, there are real consequences to what seemed like I was just doing my job, you know. But it's creating the space. It's not asking everybody to be a social worker, but it is asking people to recognise that people need help navigating the complex systems that we've set up.
Yeah, really important. Did you want to add something, Kiri?
I was just going to say, I'm conscious of time. I just sort of one other point going back in terms of that, you know, the institutional systemic responses and stuff. I think that with this report, what we've tried to do is, you know, Femicide actually positions gender-based violence as a human rights issue. Yeah. And with something being framed as a human rights issue, that actually places that ownership on the government and on the system, you know, to prioritise the safety and well-being of women and girls. So I guess it's a bit of a call to action, you know, for that responsibility to be taken up as well. So absolutely, we, you know, have taken that into account with the report, and hopefully we can help to get those messages out as well, because it's an integral part of it. You know, we can only do so much as individuals at the community level at the end of the day if, you know, the state's not taking ownership of its responsibilities.
That's good. Thank you very much. We've got a question in here that's kind of going off into a different part of your data set. Someone's asked about the 2020 to 2022 data, and that it didn't mention the impact of the COVID lockdowns. We're wondering whether you had looked at that. Did that have an impact during the COVID period?
Yes, I can answer. I was talk to that, Nicola, as well. I know I've had quite a few conversations with my colleague who is responsible for the perinatal and maternal data. And yeah, I mean, we definitely, with our family violence data, had changes over that period as well. But yeah, definitely has impacted those numbers. But I think worryingly, those increase in deaths over that time have continued post-COVID. So that's, you know, we haven't seen that drop back down. But yeah, absolutely, people were, you know, locked down with their abusers. They were pregnant, having babies, losing babies, all of this complete, I guess, you know, a lack of optimal supports. And so that, yeah, absolutely impacts everything. So yeah, I know there's been some work done in that space. We didn't go into that particular detail with this, but absolutely has contributed to those figures.
Thank you. Thank you very much. I wondered whether you could talk a little bit more. We've got a few more minutes. You did, in your recommendations, talk about the importance of interventions and taking a life course approach in that, thinking about the accumulation of trauma and historical and ongoing harm. So I wondered if you could just talk a bit more about what that means to take a life course approach. What does it look like in practice for people within their jobs?
Yeah, this is very dear to my heart because we have a system that kind of segregates and puts priorities on people in terms of access to services and thresholds. And what I think that leads is to a narrowing focus on what's actually happening to a person at this point in time and what we need to do to fix that. And a life course approach means that we always understand where a person is at in the context of their whole life. So that means we're thinking about the bigger picture of their experience. But in terms of how we set the points for intervening or offering support, the message behind a life course approach is the earlier the better. And so we currently invest a lot of our funding in the high-end services, so critical services, what they call tertiary level specialist services, and that we're not investing as heavily as we ought to be in what we call prevention early intervention. And prevention early intervention comes down to the earliest opportunity to offer support in the life of a child or a life of a person and also in the life of a problem, because not all problems emerge in childhood. But at the moment, particularly in our very resource-constrained environment, you have to be really bad to get any kind of response. And unless we really tackle there's a very difficult period when you're shifting, because you're funding those high-end services at high rates at the same time that you need to start seriously funding prevention. And there's a gap between when you get the return on getting the early intervention prevention right through, because over time that then reduces the demand for higher level. We haven't yet seen a government who's willing to take that risk, to commit to the long-term project that is literally shifting our societal settings to get people to this support at the point where it's going to be most effective, and suck it up in that period before we see the reduced demand. If we were serious and we got it right, we could quite quickly, I believe, reduce the numbers in prison, for example, because when we don't get it right for young people, we know they go on a trajectory to prison. If we were to invest intensively, I think we would, you could get returns within a foreseeable period. But it's and I think the other thing too is that we still tend to be dominated by top-down approaches where certain policies or certain practices are deemed to be the best way to go. What we see in the family harm field particularly is that the most effective responses are community-initiated and community-led, and they are responsive to the particular community that they're serving. And that, one of our plugs, our consistent plugs, is that we need to enable that way of responding through our funding models, and currently we're not there yet.
Yeah, thank you. And you have highlighted some really good examples of those community responses in recent reports too. So thank you, appreciate that. We're nearly at 1 o'clock, so I just want to say thank you so much for sharing the really important information. Thank you for answering some of the questions. Sorry we didn't get to all of them, but Kiri has shared her email, so people might reach out to you if they've got any other thoughts. Thank you. Thanks. I'll hand over to Liz.
May I too add my thanks, Kiri and Nicola. Thank you for your service. Thank you for your leadership. Your insights and wisdom born through many years of service is really much appreciated. So thank you so much, and wish you both well in the journey ahead. To our viewers, we trust you have found this session informative. We thank you for showing up. We thank you for your questions. As Shirley had mentioned, you've got the email address for Kiri, and I'm going to give you one for ours if you have any other questions. But we certainly want to appreciate your feedback and ideas for future sessions, both in content and the process and how we run things. So I want to acknowledge Cheryl, who's the glue behind the scenes, and Dr. Alana Oakley, who's stepped in, a principal advisor with the unit, but here providing the tech support. Next month, Wednesday the 27th of August at noon, we have Marina Carmen, who is the Executive Director for Prevention, Advocacy and Social Change as Safe and Equal, which is Victoria's family violence peak body. So Marina will discuss primary prevention of violence with LGBTQI communities. So I think that'll be something really interesting to hear. So make sure you get on our email list by emailing us at relationships@tepunaaonui.govt.nz. I'd now like to offer a closing karakia to clear the pathways forward and offer you a safe and productive day for you all. Ino tātou. Kia tau kia tātou katoa. Te ata whai o tō tātou ariki a ihu karaiti. Me te aroha o te atua, me te whiwhi ngā tahitanga ki te wairua tapu, ake ake ake, amine. Tō whāsau fua.